Forward bending, yeah, this is a forward bending mobilization. Okay? Forward bending mobilization. And we might think about it as a way to open up spinal segments. Okay? Now, we're opening with forward bending is different than the side bending one we just did, because with this one, we're opening both sides. So you might say, what's opening? Facet joints are opening, IVFs are opening, spinal canal is actually opening and increasing in longitudinal volume, right, as we're doing this. So this might be good for, you know, a syndrome that we're looking at with our patient of maybe a flexion principal dysfunction. Flexion dysfunction syndrome maybe, right? We're just trying to increase more flexion. Or this may be somebody who is a Delito flexion specific exercise regimen. We're trying to create a flexion biased approach. This may be a lumbar mobilization syndrome patient, right? You guys with me? So we're just trying to create more motion. We can't deny that along with opening up these facet joints, we're also stretching myofascia, right? So we're also engaging that and doing that as well. This is not a very specific technique. I'm attempting to slow down, to inhibit, to hinder the segment above that I'm trying to mobilize, but I'm not with any degree of certainty able to do that. Okay? Now the picture shows using both legs to do this technique. My strong recommendation is to use the top leg. Both legs is very challenging to do. If you have a smaller patient, you may choose to do that. Using the top leg really is just as effective in many cases, in my opinion. This translates very easily, which is why we did the PIVMs, of the flexion PIVM. So if you remember the flexion PIVM, the patient is close to me, but how close? If I flex their hip to 90 degrees, about a third of their thigh or so should be off the edge of the table, right? So they're not on the edge, but about a third. So I'm going to have her move a little closer toward me. That's good. Okay, the bottom leg is going to bend. I'm just going to kind of leave that. It's going to provide stability for her. Okay? And I'm going to simply take her tibial tuberosity here, and I'm going to place that right into my ASIS. So you remember we had that waiter hand position where I'm kind of holding under her leg, and then that tibial tuberosity is right in my ASIS. So I'm able to kind of do this pretty easily. And we talked about the fact that we're going to hopefully get you guys to the point where the patient's close enough and you're getting good enough at this where you can actually do this without, you know, look ma, no hands, right? And the reason for that is I'm going to use these to mobilize her, right? So you'll say, wow, their thigh's big and I got to really, really reach, and that's a component of it for sure, okay? Not in this patient, but it could be. Think about most of your patients are not going to require a lot of hip flexion to engage the lumbar spine. All of you guys have a lot more motion in your hips than most of your patients, okay? But what I end up ultimately doing is, with this technique, is I end up flexing her leg, and I probably drop down a little bit on her tibia. So by the time I actually do this technique, I've really got it here. And what I'm really working for is I'm not working this motion here, because that's hard to control. But I kind of have her flexed up, I've engaged the lumbar spine, and now here's where I'm working. I'm right here. So this hand is going to mobilize. So let's say I'm targeting this segment right here. This hand is going to mobilize. So I'm just simply taking that hand, and notice I'm kind of grabbing her lower lumbar segments, her sacrum, her ischial tuberosities, or I'm kind of bringing all this along for the ride. This hand, I'm just trying to slow down above. I'm doing a little bit of a skin lock here and just slowing this down. I'm kind of holding. Notice, I can't block this with this technique very well. So I'm slowing it down a little bit. I'm monitoring what's going on here. And the technique is basically I'm taking this hand, holding this one steady, taking this hand, and I'm trying to pull her pelvis off of her body. Okay? So I'm trying to do this. So I'm flexing her, and I'm taking with this left hand, and I'm pulling, and then I'm kind of oscillating at end range. And then back again. So I'm taking that, and I'm pulling. For her, it may just feel like a knee chest exercise with overpressure. That's what it might feel like for her, right? So I'm kind of stretching things, I'm working things in that fashion. Another way of doing it, and I'll show you this just briefly because I think it's valuable, maybe lie on your back. And this isn't pictured there. If you have the patient close, if it feels like a knee to chest exercise, and a patient's familiar with that, well, I can translate this knee to chest exercise directly into a mobilization. So a patient's doing her double knee to chest, right, her 2KTC, double knee to chest, and she's doing that. And now what I'm saying is, you know what, I want to focus or localize force a little bit more at these lower lumbar segments. Because when she does this, everything's moving, right? So how do I localize that force a little bit? Very, very easily. I'm just going to basically take her, move her over to the side. I'm going to take my open hand or fist hand, okay, but I'm taking it, I'm kind of grabbing onto her sacrum. So I'm basically at that lumbosacral junction, and then I roll her right back onto my hand again. Now, what's really nice, you can go ahead and let go for me, is I can actually do a little bit of a scooping technique. Now it looks like, man, that requires a lot of force. I mean, how are you lifting that person? You can tell, I'm able to talk and still do this. So we're not talking about a lot of force. I'm thinking about an axis through her hip, and I'm simply trying to scoop. So I'm scooping. I'm not like doing this, right? I'm not lifting her whole body. I'm just kind of scooping. And this is a nice kind of flexion, opening. It's exactly like what I just did in side lying, except it kind of really translates that knee to chest exercise that she's home doing into a more specific stretch for that lumbosacral junction. Move her to the side, take my hand out, and then we're good to go. So I'm going to do a little bit of those and then have her follow that up with some knee to chest. So again, it's just a flexion, opening kind of mobilization.